Population Health in the School of Health-Related Professions. He has a clinical position with the Division of Infectious Disease, working specifically at the intersection of disease and the social determinants of health. Dr. Dobbs has a long career working at the crossroads of clinical medicine and public health as a physician, researcher, and public health leader. He's held numerous positions of leadership roles with the Mississippi State Department of Health, including state epidemic, you know what he is, and the state health officer, a role through which he directed, the COVID. You saw him on TV every day, and it was always fun to watch those conferences, Dr. Dobbs, and you brought us hope during those times too. And, he's also recently been named the endowed chair for the study of health disparities. So, Dr. Dobbs, let's welcome you. Come on up. Don't you feel like you know him? I mean, how many times did you see him on TV? Not but once a day?
Aren't you glad not to see you?
Well, I'm glad that pandemic is over. Yes, sir. I'm very glad of that. All right, I've got some questions here for you. Susan, is this time for the questions? Okay. Your first question is this. Mississippi is a very rural state, which lends itself to healthcare inequities and disparities. Would you mind explaining the difference between inequities and disparities?
Yes, certainly. So, great question. They're kind of interrelated, right? And so, if we think about inequities, that's going to be an imbalance in resource or access to resources, right? And you hit on the rural issue. And we know now, we look at different inequities that exist. Rurality is actually one of the biggest predictors of adverse health outcomes, or early mortality, or lack of response. And that's especially true for cancer. So that's going to be the inequity is access to screening or treatment. And then the disparity is going to be the result, right? It's going to be to rural folks, to folks who live in poverty, to folks in minority communities. Are they going to do more poorly because of those inequities? And that's really where they sort of balance the inequities that cause the disparities.
Well, look, you've answered the next two questions. So we'll move on to, does Mississippi have a report card in the area of cancer awareness, prevention, and treatment and survival? If not, would there be the grade? What would be the grade and why? You didn't know you were going to be the teacher and give everybody a grade, did you? Are some cancers more of a problem? And in what areas are we doing well?
So we have multiple, we don't have just one report card, right? We have multiple report cards, and it's dependent upon all the different factors. Now, I'm going to go ahead and say, overall, we don't perform very well, in the sense that we have the single highest cancer mortality rate in the country. All right, so what is that about? Is it because we have more cancer? It's really not. We actually have, we're kind of like more middling in the range, especially for the Southeast, in the number of new cancers. Is that we don't have as many survivors. And so that's a real challenge, and that really speaks to some of the work that we have before us. If we think, how do you prevent cancer? Or how do you intervene early? There's different things to that, right? I mean, we have to have healthier lifestyles, and we're number 2 behind Kentucky in lung cancer death, right? So too many people smoke, so that's something that we want to work on. But also, too, when it comes to screening, especially when we think about access to screening capabilities with our sort of evolving healthcare landscape where there's fewer and fewer resources in communities in greatest need, then we're going to get cancer later, right? We also have a treatment gap. If we look at what happens specifically with breast cancer in the state of Mississippi, we see some major and stark outcome inequities or disparities, in the sense that, especially among Black women, we know that Black women have a similar screening rate for mammograms, but the mortality rate is about 50% higher. Now, why is that? There are some genetic variabilities in the tissue types, but I really think a lot of it's access to the most effective treatment, also early in the course of diagnosis. So there is really simple stuff that we can do in addition to the exciting technology. If we could just get the basics right, we could save a lot more lives.
The COVID pandemic presented Glasses help a lot. The COVID pandemic presented new challenges for all areas of healthcare. More specifically, what challenges did newly diagnosed cancer patients and cancer survivors face? And can you discuss lessons learned in communicating information during the pandemic, especially for cancer patients?
Yeah, I think one of the things that was the most lamentable as far as cancer was we had a major drop-off in our cancer screening, our mammogram, our colonoscopies. And it makes a lot of sense because especially for a long time, folks didn't want to go into the clinic. We get that. There was disruptions. There were, and health system was overwhelmed, and so some of the routine stuff got sort of put on the back burner. And unfortunately, what happened, instead of there being, after these waves, a rebound of getting the procedures done, people just gave it a miss, right? I didn't go to the dentist for 2 years, right? So, because things were so busy, I think the same thing happens. People said, well, we're just going to put things on hold. And so we know that in Mississippi and in the rest of the country, we're going to see a lot more tumors diagnosed later in the course because we have this delayed screening. So we need to get back on that. We need to keep that forefront whenever we have some sort of disruptive event like this. When it comes to screening, we actually, you said our positive stuff. In some things we do pretty well. When it comes to mammography, we do reasonably well. When it comes to colon cancer screening, we actually have met some of our targets, whether it's going to be colonoscopy or other forms of screening. But I think where we really fall short is going to be making sure that we bring those benefits to all populations, rural, poverty communities, but also making sure folks have access to the best possible treatment. Because we do see, the technology or the medications out there now are absolutely phenomenal. How many of you guys know somebody who they said you're not going to make it, and like 5-10 years later, they're still kicking and doing great? Yeah, me too. There was a colleague of mine who had advanced metastatic lung cancer 10 years ago. She was like 40, and she's still alive, right? But she got access to these really advanced molecular targeted treatments that we have available, but that's not available to everybody. And that's the problem. We need to make sure we bring the best of what healthcare, the best of what health technology, the best of the future, so that everybody in the state of Mississippi has access to these remarkable treatments.
Can you explain the social determinants of health? How can poor social determinants of health potentially impact cancer patients, their care, and outcomes?
So when I say this, you'll be like, I don't know about that. But then as you think about it, you say, oh, that makes perfect sense. Only about 20% of our health and well-being has anything to do with whether or not we can go to the doctor, whether or not we have insurance, which is important, or whether or not we have a hospital nearby. So what's the other 80%, right? And I think if we think about it, we know it's going to be the other stuff. It's like, do I have a good job? Do I have stability? Do I have good housing? Do I have a supportive family, right? Or was I exposed to a community where smoking was allowed? All that sort of stuff. And then when you look at the health outcomes of where we have a lot of differences, so one of the things, it's actually, your timing's perfect for me to come to the conference, is we've engaged on a really aggressive health disparities, health equity project within the school, and also at UMC. We're trying to advance our health equity work, and we just did a report looking at health outcomes and mortality differences in the state of Mississippi, which will be published in the next few months. And what we see is that for the highest tier of folks in Mississippi, the cancer outcomes are pretty good. But everybody in Mississippi is not the highest tier, right? Even when we get to a lot of middle-class folks, working-class folks, people who are lower in the socioeconomic ladder, they do very poorly. And so this is the stuff that drives the outcomes. One of the things that we have, which is pretty cool, is we have a thing called Merle Evers Williams Institute for Elimination of Health Disparities. It's a long title, but it's a social medicine clinic. And so people who don't have housing, don't have food, don't have transportation, we get referrals. And a lot of our referrals are for people with cancer. A lot of our cancer patients on chemotherapy are homeless. They live in their car, right? A lot of them, because of the financial burdens of the illness, have lost their housing, right? So how are you going to have a successful treatment course if you don't have anywhere to stay, right? So that really speaks to the social determinants of health. It's all that stuff. If you're worried about where you're going to eat today, you're less worried about your chemotherapy in 2 weeks, right?
If you're worried about where you're going to sleep or where your kids are going to sleep, everything else is less important. It's those foundational survival things that supersede everything. And if we don't have that essential, we can't thrive. Make sense?
Absolutely.
All right, great.
Thank you so much. Let's thank Dr. Dobbs.
And I'm going to apologize. I've got to go give a talk in Laurel after a little bit, so I'm going to visit for a while and then I'll step out. It's not because I don't love the conference. So thanks.
Thank you.
Thanks.
All right. Our next victim of this interview process is Dr. Angela Filzine. And I got to tell you, I have never been hurt at the dentist, but I'm still scared of dentists. Good morning. Thank you for being here.
Thank you for the invite.
You're a native of Madison County,
Yes,
a
sir.
graduate of Tougaloo, and received her Doctor of Dental Surgery degree from,
Meharry Medical College, School of Dentistry.
now tell us where that is.
That is in Nashville, Tennessee.
Nashville. All right.
Yeah.
Did you do a little country music while you were up there?
I did, and I enjoyed it.
Good. She also holds a certificate of training completion in general practice of residency program, where she served as the chief resident during her scholarship. Recipient of the National Health Services Corps Scholarship. Dr. Filzine has committed her career to serving medically underserved and underinsured communities as a healthcare provider. For 8+ years, she served as chief dental officer at the Good Neighbor Health Hair Care Center in Houston, Texas. She's a published author, entrepreneur, and servant leader. She joined the Mississippi State Department of Health in 2016 and currently serves as state dental director.
Yes, sir.
All right. I feel like I should have flossed this morning.
Oh, you still have time.
I promise you I floss every day. Do this at the dentist every time. Tell the same lie to my own dentist, okay? How important is and what type of dental care should a cancer survivor receive? Is it different for a patient going through active treatment?
Thank you for that question, and thanks again for the opportunity to have oral health at the forefront of the conference. Oral health is very important to one's overall health. So whether you have cancer or you don't, we really recommend patients getting in at least every two times a year for a comprehensive assessment if you've never been to the dentist, and then for a periodic exam and about 6 months later to recheck things. But we also encourage persons to finish treatment, and that's where a lot of people stop, is they'll get the exam, but they don't actually get the treatment that they need. Now, this becomes more important for patients who have cancer because nobody is planning a diagnosis. So if you have treatment that needs to be rendered, ideally, especially if it's surgical, we want patients to get in at least a month prior to any start of therapy. So we really encourage the dentist being a part of the care team, so that we can properly plan with patients what is needed, whether the patient is having radiation therapy or whether or not it's chemo or a combination of both. There are various complications that you can get: sores in the mouth, dry mouth, difficulty chewing and swallowing, all of those things. So we can help to factor that in and work with the oncology team to assist.
All right. What type of cancer screening occurs in a regular dental exam and cleaning? And how effective is this in finding cancer, and what type of cancer is most often found?
Okay, well, thank you. For dentistry, the cancer screening that we usually do is the head and neck oral cancer screening, and this is just a little plug for the month of April. We usually acknowledge it as a national observance around oral pharyngeal cancer screening. But the standard of care in dentistry is to make sure that at each exam, the patient has an assessment of the oral cavity. So you may notice your provider not only taking a look inside, but outside. So we term that an intraoral, extraoral exam. So we're looking on the outside, assessing, how you smile, your lips. We may palpate or touch the lips to make sure that there are no tumors or lesions in the lips. Then we go a little further in the inside. And a lot of times as a patient, you're experiencing this without even knowing. The dentist may not say, I'm doing an oral cancer screening, but that's actually what he or she is doing. And then when we take a look inside, we're also looking at the salivary glands. We're touching those areas. We're pulling out the tongue a little bit, looking underneath, because one of the most common cancers in the oral cavity is squamous cell carcinoma. And so basically we encourage patients, if you find a sore in your mouth that's red or white and it, is there past 2 weeks, we want to make sure you get in to see the dentist, because usually it means something is going on. It doesn't have to be cancer, but definitely we need to find out what it is. And with so many other cancers going on, the patients, especially who have cancer, and let's say they are, have nausea and those types of complications, of course, that can cause some other things. So we do want to make sure that we're doing those screenings. And usually as a standard practice, I don't wait until, that time that the patient comes in for exam. We're trying to do that every time the patient comes in.
I just having flashbacks of one of Dr. Dobbs' colleagues at UMC used to be my dentist, and Bill Boatler, make you stick your tongue out, and he'd squeeze it with gauze.
Yes. Exactly.
And tell me how many people died of tongue cancer in a year while he was doing it. And Joe, you've done it twice, but you're a thriver.
Exactly.
Not a survivor, a thriver. All right. Does improper oral health lead to cancer?
Well, we do have some recent studies. I think one came out last year around head and neck cancer or squamous cell carcinoma as far as poor oral hygiene. When we talk about poor hygiene, most patients think about acute symptoms, pain, swelling, not brushing your teeth so you have the plaque, the white stuff when you get up in the morning that's there, that's still there. So there are some studies that indicate that patients who have head and neck cancer who had poor oral hygiene, if it were better, would have higher survival rates. And this indicates maybe 5 to 10 years. We know that poor hygiene does leave the mouth in a bad situation with more bacteria. The mouth becomes more dry, so it's more prone to cavities. If you have poor hygiene, say, for example, you've been diagnosed with gum disease. Some people call that pyorrhea of the gums, the official name periodontitis. We know that not only are you having problems inside the mouth where you can see, but also underneath the gums where the bone is. You're having destruction of the bone. And so think about that from the perspective of a patient who has cancer, who's now having radiation, who's taken a lot of strong drugs. All of those things are amplified. So there are some associations with poor oral hygiene and the risk of cancer.
I believe you just made me a flosser.
Yes, sir.
A twice a day flosser.
I've done my job.
Thank you. Are there any changes in diet that a cancer survivor should adhere to while going through treatment or after treatment?
Sure. We know Dr. Dobbs alluded to it earlier. We have to change our lifestyle. So eating healthier is important, whether you have cancer or not, but especially because, of course, persons who have cancer may be more tired. Your immune system is working charged to keep you healthier as possible. So fruits and vegetables and whole grains and high fiber protein diets. We know that patients sometimes who have cancer, they may not feel like eating all the time. So keeping that in mind, you may want to eat when you're the hungriest throughout the day. So your schedule of eating may change, or snack throughout the day, or drink more fluids without food, so that when you're eating, you're not getting full by the fluids and the eating. So maintaining that fresh fruits and vegetables, plant-based diets are really important for persons who have cancer and without.
Should a patient going through treatment expect loss of teeth or gums? You're not going to lose your gums, I know. You might have a little loss of gum, but you're not going to lose your whole gum.
Exactly. Thank you. So, no, you don't lose your gum. Of course, there are oral complications, as I shared before, with cancer therapy, whether that's radiation or chemo. But what we tend to see also is some of the drugs with chemotherapy may cause a bone loss. So those supplements that your doctor may provide as far as vitamin and calcium is going to be important. Sometimes with cancer therapy, you do have bones that may fracture a little bit more. So that's why it's really important, especially if you have a diagnosis, to get in prior to having treatment rendered, because we do have this thing called osteoradionecrosis that happens with patients who have head and neck radiation. So say, for example, patient needs to have an extraction done, and he or she doesn't do that prior to treatment. Now you've had radiation to occur, and your bone is not the same. Then you can have more problems with healing. So there are some complications that are associated. And in a nutshell, just getting in to see your dentist, making sure your dental team is a part of your treatment. And sometimes throughout treatment, things may change. The dentist may need to consult with the provider as far as your blood levels, if you're ready for dental treatment, your platelet count, other, things that indicate if you're prone to infection. But the main thing is that, yes, there will be some complications. No, it's not always that you'll lose your teeth. But maintaining good, proper hygiene and staying connected with your dental team is going to be important during the process.
Thank you so much.
You're welcome.
You've been a great guest.
Thank you.
All right, Dr. Jean Ann Suggs. Come on down. You're our next contestant. Dr. Suggs completed her MD PhD at UMMC and practiced radiation oncology at Baptist in Jackson. She's married to Major Brad Suggs. The Suggs live in Flowood and have 3 amazing children, 7th grader Jake, 6th grader Katie, and 5th grader Lucy. Dr. Suggs and her family attend St. Mark's United Methodist Church, where she's actively involved in the choir, kids ministry, and youth activities. In her free time, she enjoys music, reading, and traveling. She also serves as a community volunteer and an advocate for cancer survivorship and awareness. How about that?
I sound very fancy.
You certainly do. What is your specialty and why did you choose it?
So I am a radiation oncologist. Anybody here had radiation? Any of y'all my patients? Yay! I try not to, say hi to y'all in public because then that outs y'all as a cancer patient. So I always have this motto that I pretend I don't know y'all until you tell me first. So I'm a radiation oncologist. So you may know cancer patients that get chemo and radiation. I do the radiation part. Radiation uses targeted radiation to pinpoint radiation onto places in your body that are not acting the way they're supposed to get rid of tumor cells. And the reason I picked radiation oncology as a career is because I'm a big nerd, and it is really fun machines and a lot of physics, a lot of math and science that goes into it. So really makes me happy to be there. And we have the best patients. We really do. So it's a good career.
Well, can you share how different treatments are equal when treating certain diagnoses? At times, patients have a choice of what they want to do, i.e. mastectomy versus lumpectomy, radiation versus AVI, prostatectomy versus external beam radiation, CK versus seed implantation, and I have no idea what I've just asked you.
Okay. So a lot of times when you are diagnosed with a cancer, you're going to have some options. Not always, but sometimes you do. And it's really important for you to feel comfortable and confident that you're choosing the best option for you and your body and your family or your lifestyle, for example. So a lot of the things he mentioned, this versus that, are for different parts of the body that can get cancer. So breast cancer, very common. You can have a big surgery with a mastectomy, where all the breast tissue is removed. You can have a lumpectomy where they just take the tissue out that's involved with cancer. And the outcomes for those 2 surgical procedures are not the same unless you add radiation to the lumpectomy. So that's where a lot of patients come into my office. Now, that's not to say that some of our mastectomy cancer patients are not also in my office. So sometimes we have to do radiation in that scenario too. But it's really important, I think, for patients when they're diagnosed with this to, of course, when you hear that you have cancer, your mind just stops working most of the time, right? That's where our caregivers come in, where they can also sit and listen and have a second set of ears and eyes. But it's important for us to hear all of our options and get good advice and guidance as to what's going to work best for us. And so I think it's really important, if you know that you want to keep your breast tissue, you're going to have a lumpectomy, but you need to know that, hey, that means at least, 16 visits with me. And sometimes that doesn't work for lifestyle. So good medical care teams are going to talk to you about all of the options that you have. So one of the next questions you asked about was kind of alluding to prostate cancer. So prostate cancer also very common. And some prostate cancers are on the low side. We don't even have to treat them. We can just do active surveillance and check their PSA blood work every 6 months or so. Some of them are not so nice and they're a little more aggressive. And then we look into treatment options. Radiation, you come every day for 8 weeks. That's what we did when I was in training. It was the only option we really had as far as external treatments, where you come into my clinic every day. Takes about 15 minutes, but it still can be a long drive for some of our patients, and that's a big investment in their time and what they have. The other options is you can have surgery, but then there's some side effects to all these treatment options. But now, I think I'm going into one of my next questions, but I'm going to keep going. So now we have some prostate cancer treatments that are not that time involved as far as coming every day for 8 weeks. Now we're able to shorten them. We're doing a little higher dose each day. So you don't have to come for 8 weeks. Maybe you're coming for 5.5. That 2 weeks can make a big difference. We have some patients that are now coming, instead of 8 weeks, they're coming for 5 times. And they're getting a whopping dose of radiation. And they're doing it twice a week. So every 2.5 weeks, 5 little trips to my clinic, they're getting their prostate cancer treated. We use a CyberKnife. It's also called SBRT, which is stereotactic body radiation therapy. And it's just when you give a really high dose of radiation in one. You got to have a good machine for that. But luckily we have lots of those here in town. The other option you mentioned was seeds. That's a wonderful we've used seeds for prostate cancer for a long time. Does not work for really aggressive cancers unless you also do at least 5 weeks of treatment. But by themselves, for low risk prostate cancers, seeds are wonderful. Love that for some of my farmers in the Delta that want to come in, get their one operative procedure, and they go home and recover. It's a great option. Then some of the breast, we're getting a lot of new research to try to really maximize the way that we're able to effectively treat cancer, but minimize, the patients and having to come every day. So we're really trying to shorten that burden of being out of pocket for work, or all those things, making them feel kind of cruddy. So we're making some advancements, and I think it's really exciting. It's a cool field to be in, to be able to do this and have some neat little toys to play with. So I think I got them all.
And just your next is to tell us about the advancements in radiation and how it has evolved over the years.
Okay, so we already talked about how, some of our treatment times have gotten shorter as far as how many times you have to come to clinic, but really that's all because our machines are getting so much better. So we are more confident that when you're laying on a treatment table, that machine that's going to move around you and make noise, but you can't see this invisible thing that I promise is happening, those are getting very, very precise. And so when we're able to confidently say, this is exactly where the radiation is going in this person's body, and we're able to spare and leave everything else alone, then we can safely go a little bit faster and get it done a little bit quicker. So that's great. The other things that are advancing is not really having to do with radiation at all. As our systemic medicines, our chemo, our immunotherapy, our targeted drugs, as those get better and better, you're going to see patients living longer that have higher stage disease. And this is where radiation becomes even more important because of local control. So that 1-2 punch of really controlling primary tumor, and then the systemic therapy that is going to prevent anything from happening anywhere else in your body, from growing and spreading, we're going to start seeing really extended life. That's really wonderful. It's really cool.
All right, our next question is for you to describe important factors in holistic patient care. Maybe discuss financial, social needs, dietitian needs, counseling, support groups, and the importance of activity.
I think that question sort of hits on why we're even doing this conference, so that you can hear from our epidemiologists, from our dentists, from our social workers, from everybody, that you're realizing cancer does not just affect the cancer patient, and it affects them and their families and their communities and their caregivers. It changes, you're not going to work every day 9 to 5. You've got, well, shucks, I've got to go to chemo for 8 hours this day, and then I'm going to feel like crud 3 days later. There's a lot of things that go into it, and I think it's possible to do cancer alone, but it's almost impossible to do it. You see what I'm saying? Like, it's a lot of my little independent people, that do everything for others, I think the Lord really works sometimes to help us realize our limitations and to rely on Him when we realize that this is not something we can do by ourselves easily. But you're right. Financial cancer is expensive. Y'all, it's expensive. Thank goodness we have programs. Thank goodness we have insurance. Social, it brings you down a peg or two when you can't do all the things you want. When you don't look the same anymore. When your hair's gone, I mean, that can take a toll on some of our ladies. And I'm into. So I think it's really, really important for us to recognize that this affects not just their health. This is not just a breast cancer that's going to get treated. This is their life is going to change. And so I think it's super important to have all these communities coming together and this awareness of what it takes to get all of us through it. You had some. Can you make sure them all?
I guess what we eat.
Oh, yeah, you gotta eat healthy, y'all. That's hard. These chicken biscuits are delicious. But I mean, we gotta eat our vegetables. It's important. The things we eat are important. I think we're seeing that. But yeah, look, activity. I love to move around. I like to go walking. I like to have fresh air. I think that's super important. But we know that if you have, if you're moving your body's going to do a little bit better. A lot of my patients will take this opportunity they're going to feel tired. Radiation wears you out. I've had one lady, she fell asleep outside her daughter's piano lesson. She was supposed to be waiting in the car. Thankfully, the car was off. She was reading a book and woke up. Oh, well, kids getting in the car. So she fell asleep. So it usually makes you tired. But if you can move your body, you're going to feel a little bit better. It's going to be a little bit easier on you. And, it's kind of like, your retirement. You work on that when you're young, you put it in so that when you're old, you can have it. Same thing with your health. When you can, do it now, start now, so that as we get older, we have it there for us.
Good advice. All right. How effective are screening methods in diagnosing breast cancer in dense breast tissue? What types of screening methods are available, and what are warning signs other than lumps?
All right, this is a good question. So, mammogram yearly is recommended for women, and then of course the age is getting younger and younger now. At least by 40, a lot of times by 35. If you have a family history, we want to get screening mammograms even sooner. But mammograms do have limitations. So we have what we call dense breast gradings. So you can have an A, B, C, or D. D is for super dense, and A is almost complete fatty tissue. So if you have fibroglandular proportion a little bit higher than fatty proportion, then the mammograms are a little bit challenging. They're still really, really good screening tools, which is why we still do them. But starting, this year, a lot of the facilities here in town and in our state have already started putting that. So you may get your yearly mammogram and it says, okay, it's BI-RADS 2. Looks fine. And then it says dense tissue, and then you got the grading A, B, C, or D. And they're letting you know that. And I think in the fall of this year, it's going to be required around the country. They have to let you know that you have dense breast. And the reason for that is if you have dense breast, it's a little trickier to spot some smaller lumps, some smaller cancers, some changes. And so there are other options. You can do breast ultrasound. You can do breast MRI, but those are it's hard sometimes to get them scheduled. It's hard sometimes to get them covered. Insurance doesn't love paying for expensive tests. Am I right? So sometimes it's a little tricky, but that's why it's really important to have a good relationship with your primary doctor who's going to be ordering and doing your physical exams. But as far as self breast exams, never going to hurt to do that. Not always going to find stuff. So it's really important to go and see the doctor too. Get your screening done.
Thank you so much.
Thank y'all for letting me come back. I really enjoyed it.
Don Waller, you're up next. Don Waller is a Mississippi licensed professional counselor since 2009 and brings a unique perspective to counseling. After graduating from the University of Mississippi with a degree in business administration, Don spent the next 20 years in the oil and gas industry in Alabama, Louisiana, and Mississippi, running a successful business and raising a family helped prepare Don for his next calling. Returning to study counseling and receiving a master's degree in counseling psychology with an emphasis in marriage and family therapy from Mississippi College. Don is now director of Summit Counseling at First Baptist Church, and You didn't mention your children and grandchildren. You should have. Man, y'all missed out on that. All right, now here's some questions for you. How does a person's faith help them function in a crisis such as cancer diagnosis? You know, without having faith, excuse me, without having faith, you're looking at a temporal situation. You're looking at you against whatever you're facing, whether you have a cancer diagnosis or not. And when I see my clients that come in and they've had something, a crisis happen in their life, most of them are faith-based. But you think about the game changer is, hey, I'm looking at something much greater than me, a power much more powerful than me. I'm looking outside of myself. And so the reframe is, it's not a temporal but an eternal situation. And I love what was Tom was praying earlier, that Jesus Christ makes that difference, okay? And so Jesus said, in this life you'll have tribulation. We don't know what's around the corner, but we know that he knows. That we know that we can put our trust in him. And so when we have a moment of crisis, when we find out that we have this diagnosis, if you're already a believer, you're way ahead of the curve, okay? And when you get to a place and you say, okay, what can I do that's going to help me to overcome this? And the first thing you do is you stop and you pray, because you realize that it's something that you need help in. All right? And then you look toward not only your family, but to your family of faith, to your church home. You don't stay home and just pray and read your Bible, which is what the foundation, daily time with God, is what helps you to overcome whatever is going to happen to you that day, whatever you're facing in life. I believe it's so important that as you grow your faith and you reach out to others and say, hey, would you pray for me? Go to your pastor, go to your church home, go get prayed over, go worship God, because when you focus off yourself onto a higher power, that's the game changer. That's the reframe that we all need in faith. And so I love what Dr. Suggs said. He said, when you have something like a diagnosis, you need to get outside of yourself. And being outside with the spring weather, being outside in God's creation, helps you to see that there is a power much greater than you that created this. It helps to give you a sense of inward focus into an outward focus, your presence in life and your desire to want to trust something greater than you, but not only greater than you, that loves you, that has provided a life outside of just this 80 years or whatever we live here. And so, in faith, it is a game changer in so much. So I did write down some verses for you guys that need to go to Scripture and be encouraged. Psalm 33, 23 says, we wait in a hope for the Lord. He is our help and our shield. In him our hearts rejoice, for we trust in his holy name. May your unfailing love be with us, Lord, even as we put our hope in you. That's Psalm 33, verses 20 through 23. In the New Testament, 1 Peter 5:7, it says, cast all your anxieties on him, because he cares for you. Psalm 34:18, the Lord is near to the brokenhearted and saves the crushed in spirit. Matthew 11:28-30, one of my favorites. Come to me, all who labor and are heavy burdened, and I will give you rest. Take my yoke upon you and learn from me, for I am gentle and lowly at heart, and you will find rest for your souls. For my yoke is easy and my burden is light. There is, God allows things into our life to test us. Are we going to grow up and we're going to be more strong in ourselves? Are we going to surrender and yield to the Holy Spirit helping us make it through the next day. Giving us the courage to speak out and say, hey, I need some help. I need others. I need a support system while I go through this next valley that I'm not sure, but I know I'm not alone. That is so comforting to know you're not alone.
But Don, when should someone who's struggling with the issue of an illness like cancer seek the help of a professional?
Good question. So when you lose, when you feel a sense of overwhelm, when you get overwhelmed, when you feel like, hey, I'm hopeless, I don't know where to turn, I'm overwhelmed, and so when you're unable to regulate emotionally, when you're able not to enjoy the things that you once enjoyed, that's when you need to go see a counselor. That's when you need to go to your regular internist and say, hey, I'm really struggling here. Medication may be an answer. Antidepressant may be an answer for this season of life. Don't be afraid to go get help. It's amazing what God will do because you're actually stepping out in faith and saying, I'm going to go see a professional. I'm going to go see a Christian counselor. Summit Counseling, which is located right here in this building, has that opportunity. We have therapists that are very experienced in grief counseling, experienced in walking with you through this. God desires for us to do this. God is very relational. And if we're going to try to do this alone, we're missing what God can do through others.
Talk for a minute about how caregivers support a cancer patient, but how we need to be sure to take care of the caregivers also.
Absolutely. The word comes to mind, boundaries. Okay? If the caregivers are not taking care of themselves, how are they going to take care of their loved one or their patient? If that caregiver is not saying, okay, if I don't get some time away, if it's a family member, come in for an hour, let me go home and take a shower, let me go home and go shopping, let me go to church and go worship, let me connect with somebody else. The caregivers are so important, but the caregivers have to have boundaries for themselves. They have to say, if I'm going to be able to love my mother or my sibling or whoever I'm walking through, if I'm going to be a good caregiver, I've got to set boundaries and take care of myself.
How do you get through a survivor's remorse when you lose a friend or family member with cancer?
So, lung cancer has a 55% survivor's remorse rate. And I think that was mentioned, Dr. Dobbs mentioned lung cancer being a very high epidemic in Mississippi. And so when you're feeling that remorse, it's usually some false sense that I had some responsibility in it. Maybe when you think about lung cancer, I should have gotten to quit smoking. And sometimes lung cancer has nothing to do with smoking. But the idea is you're trying to put the guilt on you. And that is a self-inflicted. That is not coming from God. That's not coming even probably from a loved one who has passed away or has died from cancer. And so the idea is, okay, would they want me to think that? Does God want me to think that? Is that survivor's guilt accurate? In counseling, having a reframe and really asking yourself, are these automatic thoughts accurate? Is that am I thinking correctly? But I think survivor's guilt is real. I think it's something that we all deal with. But the idea is it does take time, and there's times where you need professional counseling when you talk about survivor's guilt. They talk a lot about that being in combat and being in a platoon and maybe some of your soldiers, losing some of your combat soldiers. But it's very real in cancer too. And so I think if you're in a situation where you have a loved one that has cancer, I think starting to work through that, assuming that, you don't know if they're going to survive or not, but be praying about that. Be asking God to help you be accurate on how you respond to that, because it is a real problem. It is a real issue.
Thank you so much, Don.
Let's thank God. And look, I'm going to get off the script here, and I'm going to invite you, if you want to, don't go anywhere, but just stand up and sit right back down. We're going. Yeah. Well, she's right. We got. All right, now let's sit back down. Y'all have stretched just a second. Doesn't feel good to stretch, but let me let you sit back down because we've got our next conversation coming up with Jimmy Wells. Jimmy Wells, you make your way up here. Good morning. How are you doing? Thank you for being here. Jimmy Wells is an RN, MSN, OCM, and a GL. Good lady. I tried to. That's the only way as I know what it stands for. All right. Jimmy has over 35 years of experience in adult oncology nursing, national certification in oncology nursing from the Oncology Nursing Society. She's been that since 1991. A master's in nursing education obtained from the University of Mississippi School of Nursing. Numerous presentations locally and regionally on a wide variety of cancer and oncology nursing topics. She is published Chemotherapy Chapter in Mosby's Oncology Nursing Advisor, first edition in 2009. Longtime volunteer for American Cancer Society and the Susan G. Komen Women's Foundation. Jimmy works with the Mississippi Partnership for Comprehensive Cancer Control, MP3C, within the Mississippi Department of Health and roles of statewide coalition chairperson and is a member of the steering committee. Currently serving as the director at large for the Central Mississippi chapter of the Oncology Nursing Society. Jimmy has served on the Heart Conference for many years, and I got some questions finally for you. All right, let's go. What/who is a cancer survivor or caregiver? Why do they need help outside the nurses, doctors giving them direct care?
The thing about a cancer survivor is that we all have this image in our brain. A cancer survivor is anyone that sat in front of a doctor's and they said, you have cancer, you took one more breath, you are a survivor. It has nothing to do with time. It has nothing to do with diagnosis. It doesn't even have anything to do with whether you're on treatment or off treatment. It's about the fact that you're still here. You still have another opportunity. So that's what a cancer survivor is. So all of us, all of you that, no matter where you are on the journey, it's not about the length of time. It has nothing to do with that. It's just that you're still here and you're still going.
All right, what is a navigator and how can navigators help during and after a cancer diagnosis?
Well, a navigator, the one thing that I always think about is kind of like having a GPS in your car. You want to know where to go and how to get there. That's what we do as navigators. What navigators do is that, and I really love that I'm the last person to speak because everything from Dr. Dobbs, Dr. Suggs, Dr. Filson, and everyone else that spoke, navigators take pieces of all of that and we help you, we translate it. Just like the translators are here, we translate that because there's such an abundant amount of information coming from so many different people. There's so many regulations. Lord help you if you get on the computer and Google cancer, it's like a million things come up. So we are the people that actually help you decipher that stuff. We help you make sense of it. We help you with the education. So wherever you are, and that's the thing, wherever you are on that journey, whether you're the person that just heard an hour ago and you need someone just to pull you off the mountain because you're about to go crazy, a navigator can be there for you. If you're the person that's in the middle of treatment and have a question about, now, what did that nurse tell me, or what did Dr. Suggs tell me was going to happen in week 2 or week 3 and I forgot, or how do I get a ride somewhere? You know, what's going on in my community if I don't have a clinic there, I don't have a dentist there that I can reach? That's what a navigator does. We actually listen first. We listen first. We see where you are in your journey, and then we help you find the way. We help you develop your own GPS system. So we just put you in the right direction. So we are whatever you need us to be as nurses and other disciplines that are navigators.
Well, tell us about some of those other disciplines that might be navigators.
A navigator is anyone that is helping. That's the thing. So there are nurse navigators, and I will say that has, thankfully, over the last 5 years, we've seen a very much broadening of the scope of nurses that are in specific navigator roles. So what that means is, particularly in cancer centers where people are getting treatment for cancers, we now have nurses that's their full-time job. All we do is, that's not all we do, not. But what we do is that we're not the nurse that's starting the IVs. We're not the nurse that's hanging the IVs or sitting with the radiation therapy patients, helping them with their procedures. We're the person that you can call and say, I don't know why I have to come, or when is my appointment. That's what we do. So they're nurse navigators. But other navigators is anyone that is helping a patient. So caregivers, those of you that are in the audience, you are navigators. You are navigators because you are the person that reminds them of those appointments. You are the person oftentimes that's taking them to those appointments. And you are the person a lot of times will ask those tough questions. Ask those tough questions because you need them. And a lot of times when you get a cancer diagnosis, one of the things we always say is bring someone with you. Bring someone with you. We say that for a purpose because there's so much information, and by the time your anxiety level is so high, you only hear maybe 1 in 5 words. So I say if there are 2 people, you get the first 5 and the second person don't get the last 5. So we need you to help to listen, to decipher. So it can be a caregiver, but it can also be someone in the community. If you're in churches, oh my God, church families really are so very supportive. So having someone in your church or community, and I always say this, is that family is not always about blood. It's not always about blood. For some of you in the audience, your experience has not been about a blood relative. I thank God for blood relatives because some of us that have really strong support, but then there are other people that will walk that ride or die person. If you got a ride or die in your life, that's wonderful. God gave you a wonderful gift. So it's not always about a blood relative. So anyone with the intent of helping you navigate or get you from point A to point B can be a navigator. I also want to put a plug in. There's a new area in the Department of Health where they've been trained throughout the state for community health workers. Community health workers, they have been around in different entities for a long time. But this is a new endeavor within the Department of Health where they have trained people within the Department of Health to go out into the communities, not just with cancer, but any health-related issue that you may be having, and connect the dots for you. So we have a lot of people that connect the dots that don't have a license, that are not nurses.
How much contact from a nurse navigator should a cancer patient who has been assigned one expect to receive?
It depends on your need. It depends on your journey. There are some people you will call them or you'll go down to the clinic and sit with them. Baby, I got this. My son, my this, and my dad. And they got a list. They got notebooks and they got it all written down. They don't need me. I need them. They're so organized, so they don't need me. So what happens is that it is a very unique experience. And it depends on what the need is. Everybody's journey is different. So we try to meet you wherever you are. So there's not a limit. There's not a number. And it's not even about when you are actively going through treatment. There needs to be navigation afterwards because guess what? There's a whole lot of uncertainty after you stop treatment. What's the next step? How do I go back to work? Should I go back to work? You know, I look kind of funny now. I don't look the same. My body's bigger, smaller, larger, more browner, lot paler, whatever it may be. There are lots of challenges in reintegrating even after. And actually, that's one of the things that I do. I'm a survivorship navigator, among other things. But I talk to people about what's the next step once you step away from having an appointment every month with your oncologist or your radiation therapist, or you're going to the clinic every 2 weeks. So how do I make that transition going back to work, going back to school, helping my children understand this? And the other thing, and I know I'm kind of belaboring this, the other thing is that family members and friends have some very unrealistic expectations of cancer survivors. They expect you to be exactly who you were before you had cancer. They want you to continue to go to the mall. They want you to continue to get those cute little shoes. And we gave you some medicine that your feet don't like cute shoes anymore. So helping them with that translation and to reintegrate, because you are a totally different being at this point. You have been through a lot. You and the caregiver both have been through a lot. And helping you to understand that, because I remember I had a phone call from a young lady in her early 30s, and she had finished treatment, was doing fairly well. And she said she was just struggling because her friends wanted her to go out and do these things that they used to do, hang out. And she was like, they don't, and she was struggling because she was trying to fit in like she did before. And what I told her, I said, it's just like having a pair of shoes that just don't quite fit. They kind of pinch your toes a little bit. They look cute, but they don't quite fit just right. And sometimes after cancer, some of those shoes just don't fit right. God has given you a new path. You see things differently. And for you to accept that, and then for your friends, people that you thought and the things that you thought was so much fun, may not be so much fun anymore. But guess what? That's okay. That is okay. I have a young niece, and I'm going to let you talk to me after this. She said, you got to do you. My little niece, I was like, what? She said, you got to do you, Auntie. Do you. So you are a new you. Embrace it. You are a thriver. God has left you here for a purpose. And it may not be exactly what it was before you started this journey. That is okay, and you will have to find your way. Sometimes you need help, and sometimes that's a navigator, sometimes that's a counselor, sometimes that's a friend, or maybe your pastor. It may be another survivor or your caregiver, but just know, embrace it all. It's another opportunity.
All right, Jimmy Wells, how much importance should a survivor place on life expectancy statistics such as in metastatic breast cancer? Is there a place for statistics? I hope that word statistics.
Yeah, there's always a place for statistics, but not in your everyday life. Statistics are important because it helps us to plan. It helps us to figure out what the next step is and what we need to focus on. But you and I, even though there's a statistic, probably 15 of them for you and I alone, but I should not live my life by that statistic. By statistics, most of you shouldn't be here. By statistics, the state of Mississippi, we don't know what we're doing. We're not doing any good things in Mississippi by statistics. So while statistics are important, and there's a lot of research, and we need those statistics to help us focus on things that we can do better. But as a survivor, as a thriver, as a caregiver, as whoever you are in this audience, statistics is not what should move you. We're all here by the grace of God. And I cannot tell you how many times, I've been doing oncology nursing a long time. I cannot even tell you how many times we send patients home to hospice. And then they come back a year later with hair, and I don't know who they are. So statistics are important, but you cannot, should not base who you are, what you plan to do, and what you want to do on the statistics. Because guess what? When they talked earlier about all these new technologies, all the new advances in radiation therapy, all the advances that we know now about screening, all of the new technology with the different medications that we're offering now, it's a game changer. It's not what it used to be. I have been doing this 37 years, and I can tell you what I did in 1986 and what I'm seeing, totally different ballgame nowadays. So while statistics are good, they make good nighttime reading or snooze fest, depending on who you are. The nerds in the room love them. Dr. Six is good, and she loves those, but it helps drive the science. It does. But don't let it drive you. Don't let it drive you.
Thank you so much. Wouldn't you like a nurse navigator like this? Thank you, Jimmy Wells. Thank you to all of our experts who shared.
From
Now,
up here. I would like to begin by introducing to you Dr. Amy Burrow. Dr. Well, yeah, sort of. Her daddy was a doctor in Tupelo, where I grew up. Amy is the manager of volunteer services at St. Dominic's Hospital. And I can either move this stand out or I can put my glasses on. Where she has been employed for over 33 years. You didn't know she was 33 years old, did you? Amy is married to Chris and has 2 grown sons who are married, Walker and Anna Burrow and Nick and Shannon Burrow. Walker and Anna are expecting their first grandchild in May. Amy, begin by sharing your story with us.
Thank you, Tom, and thank you for inviting me today to come speak. And this conference is amazing. I've had a great morning hearing from the professionals. So I'll share my story with you. My cancer journey started Christmas 2015. 2 days after Christmas, I woke up and wasn't feeling very well, and I had noticed a lymph node had popped up. Just didn't have it the day before, woke up. And it was the weekend, and I happened to have my GYN yearly appointment on Monday. It's very fortunate. I went in, got checked, mammogram was negative. My son had the flu, so we thought maybe I had a virus. So got on some antibiotics and went home, didn't have any problems, felt better the next day. 3 weeks later, I came home from work one Friday and I noticed my left breast was swollen. Of course, it was Friday, 6 o'clock, weekends here. And I knew something was wrong. And I didn't feel bad, but there's, something definitely wrong. Went in on Monday, we did an ultrasound, and I found out later when I read my report, couple of years later, when I went back and started looking at all my diagnosis, the radiologist moved in. And I say from the get-go, that care team took care of me. And he said, we need to rule out inflammatory breast cancer. And I'd never heard of that. I don't know if have any of you heard of inflammatory? Okay. And at the time, did not know that, but had a biopsy the next day. And my husband and I were there. The doctor said, love to go on and get this done today if we can. We can schedule you for surgery to do it, but if you can stand it, let's just do it today. And in my mind, I'm thinking, yeah, because I got stuff to do tomorrow, So yeah, let's do it. And my husband and I left his office before we left St. Dominic's Medical Mall. They were calling us back up. And I literally think they had taken my specimen down to pathology and had it read that quickly because they knew before I knew. And so Dr. Q, I don't know if any of you know Dr. Q was mine. I was immediately sent to his office that day. And he said to me, I think this is inflammatory breast cancer. We got to wait for the pathology to come back to determine what type of cancer. We're going to go in and get you started because it's extremely aggressive, very rare, and very scary moment in our lives. I was in my office an hour before that working, and he said the most amazing words to me because I said, what does this mean? And he said, well, statistics. We're talking statistics earlier. He said to me, Amy, how do you want to live? Do you want to live 0% or do you want to live 100%? And that's all the statistics I got. And I said, well, 100. He said, okay, well, we're going to fight this. I need you to let me worry about this for you. And he knew me well enough to know, put your phone down. Quit looking. Put your phone down. Let me do your worrying. And I literally walked out that day with that in my heart, that I'm going to let this go and let my care team take care of me. Proceeded with PET scan, and the pathology did come back. And I did have inflammatory breast cancer. I had triple negative inflammatory breast cancer. Biopsy of the breast, biopsy of my lymph node showed that it had metastasized to HER2 positive. If you know the cancer world, you know what that HER2 positive. And the PET scan, it was in my breast, my lymph nodes, my sternum, and my lung, left lung. That quick. And Dr. Q said to me, we're very fortunate we caught this early. And I said, early? I said, early is getting to church 20 minutes early. This is not early. So this was all new for me, the cancer world, understanding what that meant, that yes, it is early, and we're gonna fight this. So I started with the chemotherapy immediately, got a port put in, started my chemotherapy. And Dr. Q did say, because it is so aggressive, that chemotherapy it'll know where to go. It's not going to have to wander through your body, wondering where to go. It's going to know where to go. And if anything positive, that was like, that's what I got. That's my positive thoughts here. And he said, yep, that's it. And it did. It went straight to it and it got it. So after 6 doses of that, I did show my PET scan was NAD, which means no evidence of disease. You've heard that term. So we did proceed with radiation. I had surgery, I had mastectomy, and then I had radiation. And I continue now. It's been 8 years. 8 years. Thank you. And I am on an infusion still. I do receive every 3 weeks, and I will get that the rest of my life, unless it stops working or my cancer, returns. And but I learned one of the questions I think y'all were going to ask me is, what was the most? I'm sorry, I'm reading your question. The most helpful.
I'm enjoying it.
The most helpful advice was Dr. Q telling me that, first of all. And then we're going to fight this. So my question was, well, how do you fight this? I mean, I'm a Mississippi farm girl. I know how to fight. Put my boots on, we're going to fight. But how do you fight this? So I think metaphorically, sometimes what's a metaphor? Sometimes I need a metaphor for me to get my hands around how do I do this? And it came up from a song I was listening to. It kind of came in my mind. It's kind of like a roommate that moves in. It's like the worst roommate you can imagine your entire life. You can imagine you've been assigned this. You didn't ask for it. You didn't get to pick. You loathe this person. They loathe you. But they're there for the rest of your life. How are you gonna do that? So that I could fight. Okay, all right. Well, this is here. So how am I going to fight this? And I will say my faith was there before. Thank you, Lord, that I had that faithful Christian husband, family. Every person at St. Dominic's where I work is praying for me. Volunteers. Had over 300 volunteers. It's a lot of prayer. And sorry, I lost my train of thought. But what I learned, because I went through a phase where I got kind of angry. I'm not a huge crier, so I got over that. I'm angry now. I'm like, why? And the way that came out in me was, I'm going to be gone. They're looking at my husband, you are going to marry somebody else. And that is not good. I'm not happy with that. That so surprised me. And I was like, this is not fair. This is not fair. I really got very upset about that. And then my children, I have 2 children. And so praying. And I remember one night on my knees, I'm literally on my knees by my bed because I'm like, are you listening? Somebody listen. You got to get this out of my heart because I cannot fight anything with this mad anger in my heart with this. I can't do it. Take it away. So I woke up the next morning and I looked over at my husband. I said, it's gone. Well, thank goodness. Because every time I'd say something to him, he'd just roll his eyes. he said, well, thank goodness. And he said, well, what? Tell me why. And I said, well, that's what God told me. I woke up and this is what God said. Amy, Chris, and Walker, and Nicholas, they were mine before they were yours. And I love them more than you even love them. And you might not understand that amount of love, but I love you that much. And when I tell you it was gone, and then I could fight. And that's what I call power of love. And that right there, to this day, I mean, the last 2 days, thank you, Jean, for inviting me to speak, because I really had to think about this these last 2 days. My husband and I talked this morning. We cried over it again. It's been 8 years. But that power of love, and it just came down to that for me. It's like I can fight it if I got love. And my goodness, all these people praying for me, all these people wanting the best for me. My son asked me, do you want me to quit school and come take care of your mom? And I said, no, but a nice haircut would be good. Do you want me to shave my head? No, but a nice haircut would be good. Couple things along the way, talking about the hair. I think Jimmy mentioned this. Someone mentioned it. Losing that hair is a lot harder than I thought that was going to be, because you got the eyebrows and the eyelashes. Everything's gone. And one day I tried wigs. It just didn't work. It just didn't feel right. It was scratchy. It was itchy. And one day I thought, I work here. I'm at the hospital. I work here. All sick here. Everybody that comes in this door is sick. And I said, I'm walking out of this door, and I'm going to walk down that hall bald. Not a person said a word to me. And that was it for me. So I look back at the pictures, and I'm like, I cannot believe I did that. But it ended up being an amazing blessing. It really came down to, I just don't want to do I didn't want to fix my hair before when I had hair. I certainly am not going to want to fix a wig. So, but I had total strangers come up to me in Kroger and stop me. Can I pray with you? I said, well, yeah. And that ended up being an amazing blessing. I'm not saying that's the way everybody needs to do it. I'm just saying that's what I was very surprised at, what strength that gave me. And just kind of part of that journey that I went through.
Well, what do you know now that you wish you'd known when you were first diagnosed?
That's a good question. So I think for me, I don't think that there's anything I would change about it. And this is why. Because what I learned about God's love for me through this journey, I wouldn't change a thing about the opportunity I had to do that. And what God changed in my life. I didn't know the depth of what that word trust means. I got the faith part. I feel like I got that part. But that trust in God, I didn't really understand what that meant. And I'm still learning that every day. But the love that God has for me and the care for me, how can I possibly think His plan for my life is not the perfect plan for me? And so I don't know that I would do anything different. I probably wouldn't have put my husband through the torment of telling him that I'm not happy with you. But I was honest with you that I don't know what to do with this. So, but I don't think I would change anything. I really don't. And would I do? I wish it would all go away. Absolutely. But I wouldn't change a thing about my faith, my trust, what I have learned. And also, God told me, you can do what I need you to do right where you are. What do I need to do? What do I do with this? Dr. Q says, you're a miracle, Amy. And I said, I don't know how to be that. I don't know how to be a miracle. God, how do I be a miracle? You can do that right here. You can do that at St. Dominic's where you work every day. If you can't do it there, you can't do it anywhere. And the place I've walked in every day of my life for my whole life, I saw it differently. Okay, so what am I going to do today? And thank goodness I have the opportunity where I work where there are people who are suffering. Wow, what an opportunity. And so I do pray that every day, Lord, I'm your instrument. Let me be that. And so.
Well, thank you so much Amy, for sharing with us today.
Thank you.
Joe McKeever is our next survivor that's going to come talk with us. Joe is a native of Alabama, the son of a coal miner. He's been preaching the gospel of Jesus Christ since 1961, writing and cartooning for religious publications since the mid-60s. He put in 42 years pastoring 6 Southern Baptist churches, followed by 5 years as the director of missions for all the Southern Baptist churches of the Metro New Orleans area. He retired in the summer of 2009. I don't know how many cartoons, this is not on one of your questions, how many characters do you think you've done of people?
I do programs for schools sometimes. I call it lessons from drawing 100,000, but truth is, I don't know.
I bet it's more than 100.
By the way, Tom, I want to say I'm very disappointed about this meeting. I came to the Hope Conference thinking I'd see Bob.
He's dead. Bob Hope is dead, I know.
He's dead? Oh.
Hope's not dead, but Bob Hope is. And look, I like your socks.
Yeah, look at our socks.
And shoes. All right.
I've got orange.
Let me get to your questions here. An unexpected blessing that you received through your cancer journey.
By the way, you left out a very important thing of my resume.
That you own staff here.
Well, I was in staff here. 1971, 72, and 73, I was minister of evangelism, except they could never get it right except calling me minister of vandalism. I'm speaking with a lisp because that's part of my story. Cancer surgery in my mouth and removed part of my tongue. The good news is I wasn't using that part anyway, so it's okay. But it left me with a lisp. So that's the second time I've had cancer of the mouth. 2004, living in New Orleans, I've been in New Orleans since 1990, and had a regular appointment with my dentist and the hygienist, the dental hygienist. Said to the doctor, there's something under Joe's tongue. And it showed me the mirror. I didn't see anything. It looked like just a silvery, almost like saliva. And so the dentist said, we'll keep an eye on it. 6 months later, I'm in there again. And here's his notes, still there. He gives me an antifungal mouthwash. Doesn't work. Sends me to an oral surgeon who did a biopsy. And the thing is, he did the biopsy right before Thanksgiving of 2004, and I got the news right after Thanksgiving 2004. I mean, is God sending you a message or what? And I have always been such good health that I go to doctors and never give a thought to the fact that this could be something bad. But then I go in, he tells me stage 2 carcinoma. And I had an ear, nose, and throat doctor in New Orleans he was almost like a family physician, treating all the family. And so when I told him, he said, I'll take care of it. So December of 2004, went to East Jefferson Hospital in Mary, and he removed it. And the thing he was going to do both chemo and radiation, I got very sick after the first chemo, so they discontinued it. And then going to do radiation, about 6 weeks of it, 5 days a week. And I said, you said you got all of it, because he took snippets of adenoids and everything else, looking to see if it spread, and it had not spread. I said, why are you doing radiation if you already got it all? He said, because the processes that gave you cancer are still at work in your body, and we're trying to put them out of business. And he said, if we don't do that, you may get cancer again. And he said, believe me, you don't want the second surgery on your mouth for cancer. Well, that's what I had, but 2 years ago. I developed I found just an ulcer on my tongue. I never had an ulcer on your tongue. And so ear, nose, throat doctor in Madison, part of the Baptist system there, tried different things, including silver nitrate. The silver nitrate, gang, is acid. And he didn't tell me in the desk or anything. He just put that stuff on there, and I came out of that chair. And anyway, still there. So went in Baptist then for a biopsy, and a few days later said cancer's back. So scheduling came in, and this time what he did was he just kept cutting until he got it all. And when I came out of the surgery, I had a swollen tongue. The funny thing, Tom, after the first surgery in 2005, 2004, I don't remember any after effects. I just walked out and I'm fine. But this time, I had my tongue through in my mouth. I could not speak for several days. When it gradually came down, then of course they've done radiation once, that's it, you don't get radiation again. And so all it does is visual checkup. I go back occasionally, does visual checkup, and over at the Baptist Cancer Park there, they do CAT scan occasionally, see this, yeah? And my endocrine doctor told him, the oncologist said, I want Joe to have Keytruda to build up his immunity system. And that was the worst thing that ever happened to me, because after 7 infusions of Keytruda, it destroyed my pancreas and left me as a type 1 diabetic. I look back, Tom, and remembered before the very first infusion of Keytruda, the nurse sat there and said, I'm required to read off the side effect sheet. She read for 30 minutes. Possible side effects. If you listen, now then you'll see advertisements for Keytruda on TV, and if you read what it says at the bottom of the screen about side effects, and one of them will be and possible death. I wonder, does anybody have any good story to tell about Keytruda? Because I think that that stuff ought to be put out of business. But anyway, so I got my speech back somewhat. My tongue looks like the west side of the map of Mississippi. You're coming down from Memphis, and then here's Vicksburg over here. So the border comes in, the Mississippi River comes in, and back out. So when you're looking at the map of Mississippi, it comes out, it looks like somebody just pulled the belt on it right there, and that's where Vicksburg is, and that's where my mouth is. My endocrine doctor in New Orleans told me the tongue is the only organ in your body that you can cut some off and it will rebuild. My EMT in Madison says, you will live long enough for this to rebuild. Be 84 later in this month, so I might just show him.
Let's show it.
Yeah.
I hope you do show him.
I'm preaching tomorrow evening down below Brookhaven, and I'm going to be speaking to pastors in Harrisburg. So whenever I go up, I tell them, I'm speaking with a lisp. I've had cancer surgery in my mouth, new part of the tongue. I wasn't reading that part anyway, so I tell you. And, but it does leave me with a lisp, and I pray all the time that this will not be a problem to anybody hearing me, because being a preacher, I somewhere preach. And I know how blessed I am, because I have about 8 or 10 engagements every month at the age of 84. Because I know guys my age who sit at home and a lot of guys my age, preachers are sitting at home wishing somebody would ask them for something. And so I am so very blessed.
And you're turning down things.
I've turned down
for rescheduling.
Yeah.
Tell these folks one thing that you wish you had known.
One thing I wish I had known before all this mess that could happen to me. So being a minister, I've been in our hospitals all the time, nursing people, everything, but, Don, over the years, there's so many doctors, and everything's fine going home. Dr. Band's my doctor, Baptist, his dad before him was my doctor. And then suddenly you come in. You know, when I was on staff here, one of your predecessors was Dr. Joe Triplett, Minister of Pastoral Care. I'd sit in staff meetings, and Joe would come about various medical problems this person's having, and people were praying for. I'm a preacher and a history major in college. I did not know medicines and stuff like that, so I didn't have a clue what you're talking about. And so I had to learn this terminology whenever I suddenly find myself.
Well, I'm going to get way off script here, sorry. But when you bring up Dr. Joe Triplett, I remember his wife telling me that when he got so sick with cancer, that his prayer was, Lord, thank you for trusting me with cancer. Look, that is a right way to pray, isn't it? And that's something you can pray to, Lord, thank you for trusting me with cancer. It's hard to get there, but boy, what a great place to be when you can know that.
Tom, like I said, I've been sketching people out here, and when they get through, if you want to be sketched, I'll be back out there, and I'll stay as long as I want to, because I don't have anything to do until tomorrow morning. I'm teaching Sunday school.
Thank you so much.
I need to go pee, so excuse me.